You, or thanks to the organizer for the invitation. It's a pleasure to be here and to give you a brief overview of the dosing aspects. So the clinical pharmacology, meaning the pharmacology in humans. So for all the research that we have seen and that we want to do, we need to know what the doses are that we are going to use, being it in patients or in healthy subjects. And this is data from 16 healthy subjects who got all these different doses of LSD to illustrate the relationship between the dose, the plasma concentration, and the effects. You can see if you increase, if you double the doses, you will see a doubling in the plasma concentration. So this is proportional. However, the concentrations in the blood or in the brain even do not relate linearly or proportionally with the effects. So the 100 microgram LSD dose would already produce a maximum good drug effect. So this is just everything that's feeling good. That could be oceanic boundlessness, mystical experiences as well. It would look the same. And if you double the dose, this is not going to increase. Of course, there is still more of the psychedelic typical effects like ego dissolution, but there is also more bad drug effects. So just getting this data from healthy subjects in a phase 1 study, you would probably then pick the 100 microgram dose to go into patients. Then you would have to do a similar thing in patients in a phase 2 study, and finally select the dose for phase 3. And this is indeed, in this case, the 100 microgram dose that is now going to be examined in patients with anxiety disorders by a pharma company. How do the doses compare between substances? So the most important comparison is probably LSD and psilocybin, since these are the two compounds that are mostly used in the clinical studies currently. And as you can see here, LSD 100 micrograms, LSD base, so that's not the tartrate, that would be higher, 146 micrograms, would be equivalent to 20 milligrams of psilocybin. So the typical psilocybin dose of 25 milligrams in many clinical studies now would be 125 micrograms of LSD. And this is kind of important because some studies, for example in anxiety, are done currently with LSD, others in depressions are maybe more done with psilocybin, but I would argue it doesn't matter. You could probably just exchange the compounds, but you would have to know what the respective doses are. And as you can see here, this would be the equivalent doses. Otherwise, another thing that was interesting in this study was that the subjects could not distinguish between the two compounds. So essentially, if they're on the peak or shortly after, and you ask them what do you think is a substance that you got, you are unable in a double-blind trial to actually know whether this was LSD or even mescaline or psilocybin. The difference occurs with the duration of the time, as you know, the duration of the effect. Psilocybin acts maybe for 4 to 5 hours, and LSD is rather in the range of 8 hours. Now, a practical question especially for the treatment of patients would be, do we have to stop the antidepressant treatment? So in treatment-resistant depression, you have heard that they would usually have already a treatment in the past with an SSRI or another antidepressant, or they may still be on these treatments. And the question would be, do we have to stop this? Would that harm? We do know today from the first studies that have looked at this that stopping the antidepressant treatment is not a big issue. You can pause it and you can then give the psychedelic, but it may not be necessary, and this has been investigated here, again, in healthy subjects. So typically, such interaction studies you would start in healthy subjects, and then if it looks good, you can move to patients. So here we treated healthy subjects just for 2 weeks with an antidepressant, in this case, escitalopram, and then they got psilocybin, and then they were switched, the same subjects, to placebo, and again got psilocybin, or vice versa. So half of them got first the placebo or first the escitalopram for 2 weeks, and then the psilocybin. And as you can see, the acute effect is pretty much the same whether you have been pre-treated with an escitalopram or placebo. It's a little bit lower with the SSRI, but it's not significant. However, there is actually a significant reduction in the bad drug effects that includes, for example, anxiety. Anxiety is already low, but it's still decreasing if you have been on the antidepressant, actually. So that is in healthy subjects. This is also can also be seen in other scales. So anxious ego dissolution is reduced with the pretreatment with the SSRI, and anxiety within this scale is reduced. So it's not just in the visual analog scales, it's also in these more sophisticated questionnaires with different items. And a critique of this interaction study was, of course, that we only pre-treated for 2 weeks and only in healthy subjects. So at least we replicated the study with a 6-week pre-treatment. So that would be then more chronic, more similar to patients who typically would be on an SSRI for at least that time or even longer. Additionally, we switched from psilocybin to LSD and compared an LSD treatment after 6 weeks of paroxetine, another SSRI, or placebo. And again, practically the identical picture, no reduction in the acute good drug effects of LSD after the SSRI treatment. However, we do see a reduction in bad drug effects and even in nausea. So they were actually doing better during this session. So it really seems you can keep on the SSRI. I wouldn't go as far as adding this to the treatment, but I would probably not stop it. And we will see how this will be done in the future studies. So far, patients need to pause their antidepressant treatment before they are treated with an psychedelic in the clinical studies. In clinical practice, at least in the limited access program in Switzerland, we have ceased stopping the antidepressant treatment and just keep it on with psychedelics. There is a limitation to the data, but maybe you have noticed it. Paroxetine is a 2D6 inhibitor, which results in an increase in the plasma concentration of LSD because this is metabolized via 2D6. So you can see that we actually have more LSD in the blood after the paroxetine pretreatment, and still the same subjective effects. So you could argue that we kind of increased the dose by almost 40%, reflected by the higher plasma concentrations, and therefore maybe if you use another antidepressant that is not a 2D6 inhibitor, the response to LSD may have been a little bit lower. This 2D6 may also be relevant in another setting. So if we treat patients who are poor metabolizers for 2D6, so about 7% in the European population would be poor metabolizers, then they have a higher concentration of LSD, and they even have a longer duration of the effect, on average 12 hours compared to 9 hours if you are a normal extensive metabolizer of 2D6. So this could also influence the dosing. This is not the case, by the way, for psilocybin. There, this enzyme doesn't play an important role in the metabolism, thus you don't have to account for this. We are skipping this here. So what are the differences between MDMA and the psychedelic? Sometimes we call MDMA an atypical psychedelic, but it's actually quite different in terms of its acute effects, the quality of the effects, and also pharmacologically, as shown here. So these graphs show you the relationship between the plasma concentration, which is linked to the dose, but in this case, it's the plasma concentration actually over time. The average plasma concentration in 16 subjects over time of a session. So the plasma concentration goes up. And you can see the subjective LSD effect on the left, which also goes up in a more or less linear manner, almost with the plasma concentration. So if you have more LSD, there is more effect, and then the plasma concentration declines, and once it's gone, the effects are also gone. This is very nicely linked. It's completely different, as you can see on the other graph for MDMA. The MDMA concentration also goes up, the effects also start, but then the effects are gone within 4 to 5 hours. But the half-life of MDMA is actually much longer than that of LSD. It stays in the blood, it stays there, it stays in the brain for hours. And it's almost not declining, as you can see. After 6 hours, we have still almost the same plasma concentrations compared to 1.5 hours, but the effects are completely gone. So there is a strong acute tolerance, which has not much to do with what's in the blood or the brain, but rather all the serotonin has been released, the oxytocin, which is important in the effects of MDMA, has been released, and therefore there is not much more to act on for the MDMA, you could say. The duration of the effect, the intensity may more be linked to something else and not only the plasma concentration. So with regards to dosing, this could question the booster dosing that we are doing, and it's still not clear whether this is really needed. What about pretreatment with the antidepressants? Can we also keep this on with MDMA? No, not at all, as shown on this graph here. So again, tested in healthy subjects. These guys were pretreated with one of the antidepressants, and serotonin noradrenaline uptake inhibitor. So this substance binds to the serotonin transporter, the uptake transporter, and the norepinephrine uptake transporter, and prevents the MDMA from binding there and releasing the serotonin. And as you can see, the MDMA response in green is much lower after such a pretreatment with an antidepressant. So if you treat the patient on an antidepressant with MDMA, you would not expect much of a response since it cannot act. You would have to stop the antidepressant for a few days, or let's say at least for 4 or 5 half-lives of the substance, in order for the MDMA to actually be able to act. Oops, sorry. There's a lot of things going on without my intervention, actually. So that means we have to stop the SSRI, but we could potentially switch to another antidepressant, which would be bupropion. So if we pre-treat patients, or in this case healthy subjects, with this other antidepressant, bupropion, we do not see a reduction in the MDMA response. Actually, it's even slightly prolonged. We see a slight reduction even in the cardiovascular stimulation. So that means potentially one could keep on the bupropion in patients who are already on this treatment. It's more often used in the US than in Europe. Or we could switch a patient from an SSRI to bupropion, which is not acting on the serotonin transporter and not preventing the MDMA from acting. And that could be an option in patients who don't want to stop the SSRI. So these studies, although done in healthy subjects, may help us decide on the dosing in patients. What about the 2D6 genetics? We have seen that this plays a role in LSD metabolism, same for MDMA, so you would see a higher increase in the plasma concentration of MDMA in these subjects who have this genetic background, and you can see also that the drug liking is higher and the systolic blood pressure increases faster in subjects who are 2D6 poor metabolizer. Is pharmacology explaining everything, or are there other factors? Of course they are. There are psychological aspects, there's the setting and the set. And this represents kind of a multivariate analysis of many predictors and outcomes. The outcomes are typically acute subjective effects, and the predictors that you have marked here are drug dose. That's this red line on top. So the dose really determines a lot of the acute response, and this has been done for somewhat more than 200 subjects, healthy subjects, and only for LSD in this graph. However, there are other things, especially if we correct already for the dose or the plasma concentration, then we have the genetics. So if somebody, as mentioned already, is 2D6 poor metabolizer, the response will be higher, or in this case it's marked in blue because the activity score means higher activity of the enzyme, then the plasma concentration is lower and the response is lower. There are two additional predictors that seem to be quite important. One is general well-being measured immediately before the session. So if somebody feels really well and relaxed and has a good mood, this will then result in much better positive responses acutely. So that's not a therapeutic response yet, that's just the good drug effect, which then predicts also the therapeutic outcome. That is what David showed us before at the end. Essentially, a good drug effect, be it mystical experiences, more oceanic boundlessness, or more good drug effects here, would predict a better therapeutic outcome in the patients then. So apparently, feeling well before the session is important. You shouldn't be distressed, should not have too much anxiety probably, and then the response is going to be better. There's another predictor, more set variable, that is if you're open to a new experience, then like as a trait, personality trait, that also helps with a more positive response. So overall, I hope that I could show you some of the aspects of dosing. There are other medications, there are genetics, there are setting and set variables, and some of the things that I showed you and some others have been compiled in the suggestions that you can find on the homepage of the Swiss Physicians Association for the Psychedelic Therapies. So the therapist can then check there what to do if the patient has a certain antidepressant, whether they should stop it or not, etc. Thank you very much.